I'm the medical director of a wound management and limb preservation center, and here are our patients. So I want you guys to think of these as wound closing cases, not artery opening cases. We're going to try and zip through a couple of fun cases here. There's just some slide summaries of the cases. So young type 1 diabetic woman, previously revascularized in their hospital, sent to us as a limb preservation center. Is there anything else that can be done? The answer is always yes. Then we look at the pictures. So just send them over, we'll figure it out. If there's something that can be done, we try. If nothing can be done, we still work with the patients all the way out, even to prosthesis counseling to avoid depression and suicide. That's the level of the deep down we get to with these limb salvage patients. So it's not just about opening arteries. It's about healing and closing wounds. So if you see here the terminal portion of the PT, is there anything else that can be done that can explain the lack of wound healing here? Absolutely. So 2 Corsairs later, reverse cart, re-entry, externalization, reversal, and we're in the loop, and then it just becomes angioplasty. So adapting coronary techniques, inframalleolar, helps in our program achieve the wound healing results that we have. Next, the same case here, just a slide summary showing you the tremendous improvement in the inframalleolar flow there. She came back, obviously restenosis is a problem. So what we did was we connected the posterior communicating artery from the perineal into the PT, pressurizing that wound, allowing the surgeons to be able to graft her, offload her, which is a tremendously difficult place to get patients to keep off of as a heel, especially in a young woman who's running around a bunch of kids. This is a patient with crisscross stents in the terminal iliac. So due to the anatomic constraints, pedal access was pursued. Directional atherectomy of the common femoral was done to essentially give him a endarterectomy-like result. Because of his advanced CKD, we did the whole case under CO2 from the foot. This was the pre-angiogram here, showing you pretty decent pictures with CO2. We consistently use IVUS, EVUS, and CO2, whatever methods we can to avoid using contrast in these patients. So essentially no flow down in the SFA, pedal access, externalization, reversal, DCBing, big boy balloons to be able to preserve and prepare for retrograde stenting. And this is Eluvia and Supera later, and he's got pressurized flow into the foot with 3-vessel runoff, all done under CO2. And amputation is avoided. This is a patient who was also scheduled for amputation using reverse cart techniques, transtibial access, large big wound there. Transtibial from the AT up the perineal, puncturing into the pop, no amputation. This is an ankle fracture sent to us from another wound care center, having trouble closing this titanium metal wound here. So again, I like showing the wound closure results, which is Sid's enthusiasm for puncturing an outback. This is mine here. It's seeing the wounds close. It's really a happy moment. So these are problems with access, and this is why we have pedal access. So we just keep offering patients more options until we can't anymore, and then we figure out a new way to do it. So here, accessing in between the frame to be able to do pedal reconstruction. Now he's got 3 vessels and a constructed pedal loop. You may be saying here, Dr. Michael, why are you showing the same patient? It's not. There's another patient who came in the following week, similar problem, after a pallet falls on his foot. So like, who do you call Ghostbusters? You call the Limb Preservation Center, and we figured it out. So this is R2P, pedal access, DCBing in the common fem, endarterectomy, and wound closure. This is a former ballerina from Europe who has a, no, she didn't shove a bunch of screws in her foot. This was a occupational hazard from being a ballerina. She ended up needing foot reconstruction. They bagged the DP. So what do? There's no artery. This is not like busting open a perclose. So you make a loop. So we essentially sequentially dilated all the way up from a 1-2 to a 2-0 to a 2-5 balloon and recreated a tarsal loop here right around the wound to be able to provide her wound healing results. And then they could graft her successfully. Non-surgical candidate, patient had a stroke, needs to walk to recover and function. Well, we have antegrade and retrograde rota to be able to line stents and then line up his SFA with retrograde delivery of stents, Supera. So this is radial to pedal, which we consistently use for these patients who need advanced access, which we have standardized. Thanks to the pioneers, many of them are sitting in this room right now. Another patient, same thing, radial to pedal to be able to get the job done, including stent delivery, debulking, whatever you need to do. So this is a father, one of our actually staff workers, and basically was told he needed amputation. So these patients essentially get our number in like a bathroom stall, unfortunately, because we're that place you go to where you just don't get to us first, right? So we're getting 4th, 5th, 6th, 7th try at the patients. This is 2 fem pops and a pop tibial graft later with multiple endovascular attempts. Can something be done? Send the patient, we'll figure it out. So we do a diagnostic angiogram, as you saw there. This is getting pedal access below the graft, wiring the graft to be able to geolocate what's going on, where has the surgeon tied off, and we work very closely with the surgeons in the hospital. And we plan these cases out to the best of our ability. This is bringing an antegrade wire in the second video, as you see here, lining it up with the retrograde wire that's in the tibial graft, trying to get around this suture and fibrotic tissue, and then we just externalize, get the wire down in the pedal loop, and now it's just angioplasty. So long balloons here to be able to dilate, and this is the end result. You can see competitive flow with that terminal portion of the anastomosis at the P3 segment there. And now the patient is doing well. He's being followed in the wound care center, and oh yeah, we debrided him right on the table right after. So the focus is wound healing. The focus is closing these wounds like you see here, and also there's supposed to be audio there, but you guys know what triphasic flow sounds like. So very happy customer, no amputation later. A trauma patient here. Unfortunately, as you know, 50% of these PAD patients have no symptoms. So after they have an occupational work accident and are disabled and can't provide for their family and are totally gonna have amputation, you can imagine what cycle ensues. So unfortunately, there are many situations where the hardware goes in first and then we have to do the plumbing. This is one of them. So just advanced plumbing techniques here to be able to get these jobs done. Antegrade, retrograde access here. This is just showing you basic steps from start to finish, antegrade per close, and with an end result that you can show the surgeons now that they can go ahead and put a frame on this patient and be comfortable implanting 10 pounds of hardware into somebody's leg. Similar case here, patient for scheduled amputation, no options. And I really don't like that word because we think together as a team to provide an option, and there's always the option of an amputation. We don't villainize amputation when necessary, but we try to avoid it, just like everybody else here wants to in the room. So this is retro rota here, going through the stents, debulking to be able to prepare that area to line it up appropriately. So I don't like bailout standing. I like having a strategy and a game plan before I go in here. So debulking to provide the best opportunity to land our equipment is a strategy that I like. So this is an interesting case using a pedal access for closure of complications, a huge pseudo post-BAV in a morbidly obese person with pulmonary hypertension. Surgeons decline them, radiology obviously decline them because you can't inject into that, you'll thrombose his leg off. So here's retrograde VBX placement to fix the complication quickly. Just some more patients here with frames, complex access. I think we're out of time, I apologize. So I'm just gonna click these slides. Oh, sorry.
I think you're okay because I think we have one canceled.
Timer went away, so sorry. All right, we're back. So another patient here, morbidly obese, young type 1 diabetic. I was told she was gonna need an amputation, mother of 3. So this is dual access debulking from the dorsalis pedis artery. And she closed nicely. This is a nice, fun access patient here. So she's connected essentially with one pipe. You can see there. So contralateral CTO in the past, maybe she didn't need that, but that's what she has. The entire left limb is stented, and you can see an anastomotic problem there in the lower left-hand corner of the screen here, or lower right-hand corner of this video. And then here's the runoff. Okay, but this is exciting because she has tibial vessels, and oftentimes these tibial vessels are protected from non-pressurized flow from atherosclerosis. You don't know what you don't know until you go and get a picture. So look what it looks like from below. That's about 9 access routes right there. We can try to do something for this patient. You can see competitive flow here with the native. You can see an atretic graft segment there. I'm not sure why it's playing, but anyway, you get the idea. So again, pedal for the win. A couple of angioplasty steps later, and now we're delivering stents. And I'm trying to click over to the next one. Here we go. So the native was actually found out to be ligated off. So we went the back route and just lined the graft with some stents, and we're able to pressurize the foot and avoid an amputation. So again, we need a plan, and we can't be afraid to take advanced options to the limits. And thank you very much.